Hi everybody. We're excited to be instructing our course for Healwell, clinical applications of pain science, manual therapy, exercise, and rehabilitation principles for healthcare professionals, coming this November in Arlington, Virginia. So just as a bit of an introduction, my name's Jamie Johnston, and I've been an RMT since 2011. And over the course of my career, I've focused a lot on working with athletes. And for the first 7 years, I worked with a local hockey team here in town. Then I was fortunate enough to work with our national men's rugby sevens team for a year. And for the past 4 years, I've been working with Hockey Canada in the women's development program, all while maintaining my private practice. And over the past 4 or 5 years, I've been going down a little bit of a rabbit hole as far as understanding pain science. And that's what led Eric and I together and started to put this course together so that we can hopefully help other manual therapists incorporate pain science and therapeutic exercise and movement into their practice.
Thanks, Jamie. My name's Eric. I've been a registered massage therapist since 2006. I currently am on the education faculty with Pain BC, and recently I completed my Master's of Rehabilitation Science at the University of British Columbia. We have been teaching this course for the last few years together and have had the pleasure of teaching it all over North America, and are really looking forward to coming to meet and educate the people down at Healwell. And people often ask, what is this course about? What are we going to do? Well, this course will provide participants with the current evidence on how to more effectively assess, understand, treat, and manage both routine and complex patients experiencing pain. We'll use discussion, practical examples, and case studies to emphasize these key learning principles. Participants will learn about different pain mechanisms, about biopsychosocial framework, how to do a biopsychosocial interview, and be better informed and more comfortable at their manual therapy, their exercise prescription, as well as their treatment planning for all patient presentations. So my big area of interest is pain and understanding the various pain mechanisms. I think these are extremely important principles of knowledge to understand for all manual therapists and any healthcare provider that's treating people in pain. In this course, we're going to talk a lot about different pain mechanisms, and we're going to focus on the differences between acute and persistent pain, and we're going to introduce some terminology which might be unfamiliar to some people, terms like nociceptive pain, nociplastic pain, peripheral and central sensitization, as well as neuropathic pain. Now, if we can recognize these pain mechanisms and clinical presentations, it allows us to focus our manual movement therapies to optimize our treatment outcomes. We're going to explore this all within a biopsychosocial framework and understand how it's applicable to clinical practice. We want to emphasize the interrelationship between the psychosocial factors with important biocomponents and explore their impacts on wellness and treatment outcomes. Our goal as educators is to give participants evidence-informed principles to follow rather than specific linear treatment protocols. By gaining a greater understanding and appreciation for the complexities of pain, and viewing our clients through a biopsychosocial lens, we strongly believe that any healthcare provider can adopt this knowledge into their current practice.
So as we mentioned in the intro, for the purposes of this video today, we're focusing specifically on patients who come in and have neck pain. So whenever we're helping our patients who deal with neck pain, one of the things that we have to do is rule out any possible red flags that they might be experiencing associated with that pain. Now, it's quite commonly believed that if a patient comes in and a red flag is present, it means that we absolutely can't treat them. But that's not the case. It may just be if they're presenting with a red flag that we might not understand. We have to refer them out to somebody who can help them better. For, say, example, their physician or a physiotherapist that maybe is trained in that specific thing. So when we look at the list of red flags, the first one we're going to look at is people with a myelopathy. Now, a myelopathy is a compression within the spinal cord. And some of the things you might see with that is a loss of bladder or sexual function, a change in gait, or maybe clumsy, weak hands. The next one we'd see is cancer. So with cancer, there might be inflammation, general malaise, a fever, unexplained weight loss, unremitting pain, sleep disturbances, a localized tenderness over a vertebral body. But that's, of course, if there's no history of trauma in that area that's caused that tenderness. And also a history of cancer. But if a patient puts on their intake form that they have a history of cancer and it was 10 or 15 years ago, it's not much of a concern now. It's more if it's a recent thing. Severe trauma would also be another one. and that would be if somebody experienced a fall from a height, or they were involved in a high-speed MVI or a rollover accident. And the next one would be vascular insufficiency. And with that, it might be that the patient is experiencing some dizziness or having some blackouts. So if you're seeing any of these things, please make sure that you follow up with them and refer them to go back to their GP to get it checked out. So now we're just going to touch briefly on getting a good history with your patients. So before I became an RMT, I was an industrial first aid attendant in a sawmill for 6 years, and I've been a firefighter for the last 18 years. So this is where I use a lot of my first aid background to help me out when it comes to dealing with these patients who have neck pain and looking at their history. So one of the things that we look at, as we mentioned in the red flags, is when somebody suffers a fall from a height. Now quite often this is misunderstood as if somebody just falls, we automatically assume that there's a neck injury. But if somebody was just standing and, say, fainted, that's not enough of a mechanism to cause a severe neck injury. However, if they fell from a height, so for instance, they were standing on a massage table and fell off, then we look at that as enough to sustain a possible severe neck injury. Another thing that I think we most commonly see as therapists is people who have been in a car accident. So if they're filling out your intake form and they just check that they've been in a car accident, we want to dig a little deeper with them and figure out just how severe that was. So there's a drastic difference between somebody who was in a 20-mile-an-hour rear ender and somebody who was in a high mechanism rollover MVI. Way bigger chance of a severe spinal injury or neck injury that comes with that rollover MVI. However, I would say for the most part, we're not going to see things that are this extreme, especially in a case like that MVI. They've probably already been to the hospital and cleared of those things before they come and see us. And a lot of these things doesn't necessarily have to be on an intake form. A lot of it we can get in just having a conversation with our patients. So we want to go through and just make sure that we screen some of those things out, see how these things, the pain that they're experiencing is affecting their secular life, and just want to make sure that it's not a major injury that they're dealing with.
So part of being a healthcare professional is knowing when to refer out and recognizing the limitations to our scope of practice or our body of knowledge. And when speaking of the neck, there's a few things we need to be aware of. First of all, it may take time for swelling to develop and compress the cord. Symptoms may take many hours or days, so they may be coming to your office not aware of the potential medical emergency they may be in. If your patient has the appropriate mechanism of injury and has neck pain, neck swelling, complaints of swallowing, or has muscle weakness and has not been evaluated for a fracture, you should refer out prior to treatment. A rare occurrence in most of our clinical practices, but very important to be aware of, are signs of cord compression. This include gait disturbances, arm, hand, and sensory complaints, muscle weakness with atrophy, or the onset of incontinence. With a new onset of these symptoms combined with trauma, we recommend that you send your patient to a physician or an emergency room.
So now that you've ruled out red flags and you understand that there's probably not anything major going on with your patient, we're going to look at ways that we can help reduce their pain by modifying some of the movements that they're doing. So quite often we'll have patients come in and they're having difficulty with rotating their neck. And probably the number one injury that we see is people who sleep on their neck wrong. They come in and they're for some reason they're having neck pain and can't figure out why, but they chalk it up to they slept on their neck wrong. So if they come in and they're having difficulty with rotation, what we can do is modify the movement or put them in a different plane of movement that mimics the rotation so that they can start to do rotation again. So what I'll do quite often with patients who are dealing with this is start to see where they're having difficulty. So we'll say that Eric's having difficulty turning his neck towards me. So then what I'll do is actually instruct Eric to keep looking forward, but now what we're going to do is rotate your upper body, but keep your chin and everything looking forward. And we're going to rotate that as far as we can, and then I'll have him pin his chin down to his shoulder, and then have him straighten out. And we can see that he already got more rotation out of that. So then he can go back to center, and I'll have them move a couple more times, and before you know it, they can start to rotate their neck better than when they came in. So that's one thing I like to do with rotation. When we have patients who come in and they're having difficulty with side bending, a great modified movement we can do is actually to shrug the shoulder. So if Eric was having difficulty bringing his ear down to his shoulder on this side, I'll actually get the patient to shrug the shoulder up to the ear, because this is still the same movement as side bending, it's just that the shoulder's doing the work instead of the neck. So we'll get him to shrug, and then maybe pin the ear down to your shoulder, and then drop the shoulder down with the head. So maybe go through that 3 or 4 times with him, and before you know it, that movement of just side bending becomes a lot easier. Another one that's sometimes difficult for a patient is just doing neck extension, so just extending the head back. So what I'll do in that case is have them just do a little bit of a chin tuck. So Eric, I just want you to think about bringing your chin in towards your chest. And then you can come out of it, and then bring that chin tuck back in again. And that motion is coming back, which is somewhat forcing them into extension. And then before you know it, that movement that they were having difficulty with when they came in just got a lot easier. Okay, so now we're going to demonstrate how you can start to do some exercise movements with your patient during your treatment on the table. So we always like to start with an isometric movement, and if you don't remember the definition of that, an isometric is a contraction of the muscle when the muscle doesn't shorten or lengthen. So basically you're just resisting them doing a movement. So as we discussed before, if Eric came in and he was having an issue with rotation, so say he's having an issue with rotation to the left, all we're going to do is I'm going to put some pressure with my thumb onto the side of his head. And Eric, I just want you to push into my thumb, thinking about doing like a shoulder check over your left side. So right now he's pushing into that, and I'm just going to have him hold it for 10 to 15 seconds. Go ahead and relax. And isometrics have actually been shown to be an analgesic when it comes to helping your patients. So even though they're having a little bit of pain maybe with that movement, doing that can actually be one of the things we use to reduce the pain. So once they're comfortable with that, and we're going to get Eric to do a little bit of passive range of motion, so he's going to do the movement all on his own, and he's moving a little bit better than he did when he came in. So at this point we can start to do a concentric movement, which is where the muscle actually shortens in length. So I'm going to do the same thing and just resist his movement, but this time I'm going to let the movement happen. So I'm still resisting into the side of his head. He's just pushing into my hand. And then I'm going to stop the resistance. He's going to come back to neutral, and I'm going to resist it again. And there we've got a concentric movement for rotation. Once the pain goes away and he's doing that effectively, we can then do an eccentric movement, which is where the muscle lengthens during a contraction. So this time, Eric's going to come and rotate over to the side with that concentric movement. And then he's going to continue to push into my hand, but I'm going to instruct him to let me win the movement. So I'm actually going to push back while he's resisting into my hand. And that's causing an eccentric movement for rotation. So the other one we talked about was if a patient came in and had difficulty with side bending. So you can do the same thing. You can kind of resist here, and you can go into the shoulder. And Eric, I'm going to get you to push into my hand, thinking about dropping your ear to your shoulder. And there we've got an isometric movement. Then you can continue to do the same thing. Eric, I want you to think about bringing your ear down to your shoulder. And he's going to push into that side bending movement. And he's flexing his shoulder a little bit into me as well. And we're going to try to go through a full range. So he's going to try to drop that ear right down to the shoulder. So there's the concentric movement. And then if we want to get into an eccentric movement, I'm going to push, he's going to resist into my hand, but I'm going to push his head back to neutral. So we could do the same thing, but you could do it with him moving the shoulder. So you're just going to push your shoulder up towards your ear. There's the concentric movement, and then he's going to resist against me, but I'm going to win the movement and push it back down for an eccentric movement.
So this was just one small example of some of the simple yet effective concepts you will learn in this course. We will be going through each region of the body and practicing manual techniques in conjunction with some of these therapeutic movement principles.
And after this course is done, you'll have the confidence in providing appropriate movement and exercises for home care and symptom self-management for your patients. We hope to see you in November.